Glad you're here to join us today. And it's a perfect day to do a webinar, Coloplast sponsored webinar for erectile dysfunction. Our goal today is to educate men and their partners about erectile dysfunction, including the etiologies, the causes, the different treatment options. And we do have a little something special for everybody. So thanks for being a part of this. If you want more help, you can scan this QR code on the screen here. Hopefully, with any luck, we'll be able to record this and you may be able to get back to it later. Of course, we have this QR code at our office too. You can text 474747 and you can get some more information as well. During this, there's a little bit of housekeeping, I guess we'll kind of get to, but there's a Q&A section, and generally it's on the right side of the screen, and you can type in any question you want, comments, feel free to type anything. It is anonymous. I know everybody registers for this, but the questions come across, everything's anonymous, and we can see it. We're going to get through it. We'll get through all these questions. So I'm your host, Dr. Lance Webush. I practice urology here in Lincoln, Nebraska. It's a wonderful fall evening and it's raining, so it's perfect for all my farmers out there. I know you're not able to get in the fields tonight, and sit back, relax. I hope you learned something from this. But again, we're here with Urology PC in Lincoln, Nebraska. So the little extra, something special tonight, we have a patient educator, and he is a wonderful, fantastic gentleman. Scott is actually, he's taking a trip right now, but he's live with us, and he'll tell us his story. There might be a little bit of a delay between him and us, so just bear with us. We may or may not lose the connection here or there, who knows, but he's going to be available. He'll be available. Ideally, he'll tell his story and go through his personal experience in pretty good detail, obviously. And then in the end, if you have questions or throughout, you can ask questions in the Q&A. And if he can't see him or something, we'll direct him to kind of help him. So are you with us, Scott? Well, we have to make sure that he can hear us. So we'll get that. We're troubleshooting in just a little bit. By the time we get to Scott, hopefully everything's working out really well. If not, it's a shame. But anyways, the agenda. So tonight we're going to talk about what is erectile dysfunction, what are the different causes, again, the etiologies, the risk factors. Most of you guys have kind of figured it out by now. We talk about the treatment options for erectile dysfunction. And then, of course, we'll get to Scott. And then any questions that we haven't went through throughout, we'll stop. So just a real quick bit of housekeeping. If you can't see this or if you're having any troubles, you can email us. You can let us know. The best browsers, obviously, being Microsoft or Chrome or Firefox. Sometimes there could be some troubles, but just try and relog back in. Again, we're going to try and have this recorded so you guys will be able to get to it later if you're having any issues. All right. So definition of erectile dysfunction. It's actually very broad. It's the consistent inability to sustain an erection sufficient for sexual activity or sexual intercourse. And it can be really a difficulty attaining or a weaker erection. It can be losing the erection or difficulty maintaining the erection. So we generally talk about 100% erection. It's tricky. You're coming in and we're talking to guys and we say, well, how much of an erection do you have? Do you have 100%, 75%, 50%? Where's it at? And that is erectile dysfunction. We want 100% as a urologist, we want 100%. So there is, of course, other components to this. Of course, there's orgasmic disorders, ejaculatory disorders, and they are separate from erection and being able to attain and maintain that erection. So Erectile dysfunction is actually quite common. A lot of guys, they are starting to see this stuff on TV. Obviously, it's been on commercials for a long time now, but nobody really talks about it when they're with their group. I guess occasionally, and that's not entirely true. But yeah, 30 million Americans. That's 1 in 4. 25% of men over 65 have ED. And again, it is separate. I mean, you can have erectile dysfunction, not have a nice, firm, solid erection, and you can still orgasm. You can still ejaculate. And so those, again, that is separate and that is different. It's by no means normal or natural. I see a lot of guys, and really, I ask everyone, they come in, whether it's for their prostate health, urination, and erectile function or dysfunction is a part of that, and it's part of men's health, and that's what I actually, really enjoy. So I ask these guys, well, are you sexually active? How much of an erection? And they'll say, well, no, but I'm 70 years old. Like, well, no, that's not entirely true. I see patients of all ages, and they're still very sexually active, well up into their 80s and 90s, for sure. So it's not necessarily natural or part of aging. Aging is a risk factor. And that's a big thing, because a lot of guys say that, and a lot of guys ask about that. And they say, well, I'm at that age. Like, no, there is not necessarily that age. And erectile dysfunction can be treated. So there's obviously a lot of causes of erectile dysfunction. Believe it or not, the penis itself is very complicated. It is a complicated organ. It's controlled by nerves and blood vessels, arteries and veins, skin, sensation. So there's a lot to it. 80% of the time, we can kind of figure out what's going on. I mean, really, truly. So, that's the majority of the time. You go through and you talk through these guys and you say, hey, yeah, here's the causes. Again, most guys, they really kind of know what their problem is. Occasionally, guys really is focused and says, hey, what is the problem? And the other part is, why is this important? And it's important because of treatment. Can we treat this as something that's treatable? And it depends a little bit on the cause. So the common things we think of is injury being related to spinal cord, nerves, injury being related to the pelvis. Of course, penile injuries, that they do exist and they do happen. Diabetes is so common, and we'll talk about diabetes here a little bit. Of course, prostate surgery. So a lot of our folks here in the urology office, they're coming in, maybe having prostate surgery or had prostate surgery or treatment for something for their prostate. And unfortunately, that can lead to some troubles with erections. And I'll show you some pictures and kind of go through that. I think you gain a better understanding here. Substance abuse, tobacco, drugs, alcohol, different medications, including medications that are prescribed and well-known side effects. There's a big push here that especially the urologist, but the patient needs to be aware that erectile dysfunction can be a component of dysfunction of the blood vessels. If it's a dysfunction of the blood vessels, then we think, hey, there's a chance you have blood vessel dysfunction throughout your body, meaning cardiovascular problem, cardiovascular risk. Does this mean everybody needs to go see a cardiologist? And the answer is no. That's not entirely true. But you definitely need to kind of look at this and say, is this patient or am I at risk for cardiovascular disease? Is this a component of cardiovascular disease or premature cardiovascular disease? And there's been study after study showing that some of these guys, especially the younger guys that don't have other risk factors, that maybe this is a sign for early cardiovascular disease. So just your common risk factors, and these are really represents the patients that we see, aging and chronic diseases. And that's a big part of it. High blood pressure, diabetes, depression, and again, back to the heart disease, or which is really vascular disease. Medications, there's a lot of medications. We're finding, more and more of these new meds are coming out and like, oh, well, I guess, we're seeing some side effects with those, and so they really are coming out all the time. But again, it's the same thing, whether it has to do with blood flow, neurologic issues, but unfortunately it can be a side effect of medications. Lifestyle is well known. Smoking obviously is a big hit for the penis. I think I explained last time on a webinar, and I won't forget this, but I saw a cigarette pack with a cigarette that was kind of bent, and it essentially said, this will cause erectile dysfunction. So we're used to these potential problems. We're used to seeing these. Of course, stress, alcohol abuse. So aging itself, again, back to, and yes, kind of harping on this issue a little bit, is because, guys just blame the fact that they're getting older. Well, that's not true, but there is a component to it. These guys, they may have more chronic diseases, high blood pressure, diabetes, or they're being treated for that. They may not have the sexual desire. Their partner may not be interested. I hear it a lot where partners are being treated for something else, and it's not necessarily them, but it's the partner, or maybe even both. So there's a little bit of decline in function, but there's also a lot more to it. And when you look at why guys are coming in to see their doctor, obviously it's high blood pressure, high cholesterol, diabetes. It's your typical American problems. This is what we see in Western medicine. But if you look at just high blood pressure itself, obviously high blood pressure itself and the medical treatment of high blood pressure can cause erectile dysfunction. On the right side of the slide, you'll see, hey, patients with high blood pressure, really 60-70% of these guys report erectile dysfunction, and 40-50% of them report severe erectile dysfunction. So that's just saying, hey, this is it's a blood vessel issue. And again, I'll show you some pictures. Diabetes, it's kind of the same for everything. The longer you have it, the worse off you are. The worse control you have of your diabetes, the higher the negative impact that's going to be. If you already have neuropathy and vascular disease, you're going to have erectile dysfunction. If you look at the increased risk for erectile dysfunction, diabetes, fourfold increased risk. So we try and keep our diabetes under tight control. There's a lot we can do with the penis, and I know I'll talk about our treatment options here, but you can protect the penis. You can protect the blood flow, just like everything else with diabetes. If you keep that sugar under control, you tend to hopefully not lose any function. Of course, you see the others here, prostate disease, peripheral vascular disease, cardiac, high cholesterol, again, high blood pressure. Common theme here. Prostate cancer, and there's going to be some gentlemen on here, obviously, and hopefully some spouses too, with prostate cancer, treatment for prostate cancer, or even just prostate surgery for something else, in general, resulting in ED. Prostate cancer itself, it doesn't typically cause erectile dysfunction. It's going to have to be pretty advanced if it did. Generally, prostate cancer, as we know, doesn't really have a lot of symptoms for the most part. But the treatment for prostate cancer certainly can lead to erectile dysfunction, whether that's surgery and potential injury to nerves or blood flow, or radiation, which can scar the base of the penis down and inhibit blood flow to the penis as well. So unfortunately, when you work with prostate cancer, you're going to see some of that. There's, again, this whole concept of penile rehabilitation, and I can kind of get into some of that, but where you try and regain it or try and improve it or see what you can do. But ultimately, there is damage done. Smoking, again, it's a well-known cause of blood vessel problems. It's a well-known cause of erectile dysfunction. You're not getting that back. You're not getting that back. A lot of the medications that are blamed for erectile dysfunction is very true. They can have erectile dysfunction as a side effect, but I've done switches. I've taken patients off medicines. I've made the phone call to the cardiologist, and there's way more to the story. And whether it's the high blood pressure factor itself, whether it's a blood vessel factor, is more likely. But occasionally you'll come across that one medicine, and it just started, it caused problems. Let's get you off. Let's change it, and maybe we can do a difference. This is where I think the bulk of the understanding is going to come into play. Is really anatomy and physiology. I'm really big on anatomy and physiology. I think it's very, very important for you guys out there to understand this, to really understand the penis. I get so many questions. I mean, not even at work, but at home, for crying out loud, everywhere, but about the penis. And really, here it is. So of course, the penis responds to, we think of testosterone and hormones. Of course, it responds to stimulation, right? Sexual stimulation and excitement. Then we see an uptake in blood flow to the penis, and the blood flow is what causes the rapid filling, the erection, the rigidity, the firmness. And then we have to maintain that and keep the blood flow in the penis to maintain the erection. The big things that I want to kind of highlight on this picture here is the penis comes all the way down underneath, way down past the scrotum, way down underneath, the prostate. So there's a lot of penile tissue out there. And then what you see, or what a man sees, when he looks down, is the external penis on the outside. As far as the penis anatomy on the inside, we really focus on these two bodies. They're called corpora cavernosa, and they're really a spongy tissue that does fill with blood. And they're on both sides of the penis, the left side and the right side. There's typically a solitary single artery right in the middle that feeds the whole thing. And those are small blood vessels, so now you start to understand, if I've got some problem with those blood vessels, I could potentially have, no erection, right? I mean, it just ain't going to work at that point. So to get an erection, to start the whole process, you have the nerve factors being released. And what they do is they dilate these blood vessels. And by dilating that blood vessels, you're going to get a bunch of blood spilling out into that spongy tissue. And that's how you're going to fill up this corporal body. And so that blood becomes trapped in there, and we start to develop an erection. And then, of course, our full erection or full rigidity is when it's completely full of blood, and those chambers really can't take any more. This little venous outflow on here, there's a couple of spots, they actually get compressed and they actually clamp down. Now, don't get me wrong, there can be very minimal blood flow through those, but typically there's not a lot. And we still have this arterial inflow, and this is very, very dilated, and you can see how much blood flows coming into the corporal bodies. All right, so that's it. I mean, that's it. That's the erection. All right, I say, hey, yeah, this is a complicated mechanism. I mean, it really is, but yet it's still fairly simple. So that's how you attack this. That's how you decide, well, how do we treat this, or what's the different process? And the simplest and easiest, and the one thing that has a ton of momentum is obviously oral therapy or pills or drug therapy. And, that's because there was so much marketing, and this was obviously discovered, and it worked. The way the medications work, they're called phosphodiesterase type 5 inhibitors. And what that did is it actually allowed the nerve system, the nerve input, to have a greater input. So you could still end up in a situation where if your arteries don't work or your veins aren't closing like they're supposed to, then you still end up with erectile dysfunction. But this was very successful for a lot of people. And then, of course, once you find that out and you can make money off of it, there's a whole bunch of drugs that come out to the market. They're all very, very similar. There's just a little bit of differences between them. And 2-3 of them now are generic, so they are cheaper. You don't have to come in, and I mean, nobody's got samples anymore. You don't have to worry about, an arm and a leg to pay for these medications, which guys were willing to do. Obviously, they made a ton of money off of these. But ultimately, it's easy now to try. It's easy to get a prescription. Kind of the secret behind it is, you really need to take it for the most part on an empty stomach, 30 minutes or more before desired sexual activity. You have to have stimulation for it to work. These medications don't just give you an erection, right? I mean, you don't just take this pill and walk around with erection. There's a lot of jokes about that, and you hear about it, but that's just not the way it works. It tends to stay in your system, for potentially 4 hours or longer, depending on which formula or which medication you use. It can take, 20, 30 minutes up to an hour before it even works. So there's a little bit of planning that goes into play. Some of these you can take daily dosing, so you don't have to worry about the planning. As with anything you see, side effects, the typical side effects that I hear about and I'm constantly writing down is headache. Some guys say, it's fine. Obviously, may or may not be worth it. You get this facial flushing, and guys will say that they feel warm. And again, these don't happen to everybody, but these are just some of the common side effects. Of course, GI upset. One of the medications has this very, very specific side effect of muscle aches, and it can even kind of trigger towards the back. If you have bad side effects, you can always try a different one, a different mechanism, and see if it helps. So definitely worth a try, definitely worth getting a prescription for, and really titrate up to the highest dose of the medication and see if it works and see what you can tolerate. When we move on to that, if a guy has tried and failed medicine, or has some side effects that he's not tolerated to, and I just saw a fella here today, he's got headache, and it's actually quite bad. He just can't do it. We can do some other treatment options, but typically we'll get into something like an injection of the penis. We can use this to do a Doppler study of the penis, and where you can evaluate the penis, you can evaluate the blood flow to the penis. But what this does is this actually works from a different point of view. This works towards the blood vessels. So it works to increase your blood flow increase your blood flow, and dilate. So it's pretty powerful medication. And you actually do have to take a needle and you actually inject some medicine into the penis. So I brought my needle here today. It's not a very big syringe. It truly is a very small dose, and the needle is actually quite tiny. It does take just a little bit of practice, a little bit of work to inject this into the penis. You inject it towards, the base of the penis or the mid kind of shaft off to the side. You have to be careful because you can injure yourself. If you inject into this part here, which is the urethra, that's a problem, right? And up here's where all what we call the neurovascular bundle is. And so you can affect the nerves going to the penis. So you have to be careful. You're supposed to have the first injection, with a physician. We have to dose you and titrate you. If you're not dosed appropriately or overdosed, it can last for more than 4 hours. Typically, it'll really take 10, 20, 30 minutes to kind of kick in. The medicine itself can cause some pain. I've seen obviously local reactions to it, penile pain. It's kind of an ache. It's kind of an unusual sensation. Bruising, of course, at the site. Some guys will have a reaction on the skin or a rash or sensitivity. The problem with this medication, first of all, it doesn't work for everybody. You'll see that some guys end up titrating to the highest dose, and it just isn't working. And you say, well, why not? Well, either we can't get that blood vessel dilated enough. It just is not dilated. It's firm. It's rigid. It's just not going to let more blood flow in. Or what we also see is what we call venous leak or venous insufficiency. And that's where those veins, just don't close off. So these veins don't get small, they stay large. And then that's venous insufficiency or venous leak. So it's just something like, that's why I say we can use this for an ultrasound or a Doppler study of the penis, because you can inject a guy and then you're going to say, hey, is his artery reacting? Is his artery getting larger or not? And are his veins closing off like they're supposed to? So you can see this is totally unrelated to the nerves, right? The nerve factor. This is all just purely local medication. So you can see we're starting to get to the source. This is a vacuum erection device. Now, this is actually a fan favorite, I'll tell you the truth. This is, I should say, more a urologist friendly. How about that? So this is a vacuum erection device here. Okay, it's very similar to the picture. All right. So as you can imagine, you put the penis in and you pump it up, and it's creating a suction. Okay, and so that suction is going to pull that blood into the penis. There's a release valve to release the pressure. But what happens is you put this on the penis, and then you pump it up, and you get blood flow in the penis. Of course, you only get the blood flow where the device is. So all that penis underneath the pubic bone that I showed you or kind of put on that picture, that doesn't get full of blood. If you want to use this for penile rehabilitation and pulling in blood, and like I said, maybe a diabetic or maybe a guy with prostate surgery, they'll put this on, they'll pump it up, pump it up, pump it up, and just try and get blood flow, or protect it, even protect your blood flow. If you want to use it for an erection, then you have to put this ring down around the base of the penis. And this ring has to be, quite tight. It's got to be tight enough to hold the blood flow in the penis and hold the erection. So it can be quite uncomfortable. The erection's a little bit on a pendulum, it'll kind of swing around. You imagine from the ring out is what's stiff or rigid. Not everybody can do it. Not everybody has the right penile size to do it. It's cold penis for the most part. Not everybody ejaculates, especially if that ring is really tight. But it is, cost effective. You say, hey, how much is something like this? Typically, they're not covered by insurance. They used to be, but they're not anymore. You go to Amazon, you can buy some really cheap ones. You can buy them at the corner store. A real one's going to cost you a couple $100, on the internet or at your local urologist. So all in all, though, that's cheaper than a lot of, medications or injections and stuff that may or may not even necessarily be working. It's non-invasive. We do like it, again, from a urologic perspective, because it is effective. It's effective at pulling the blood in. It will get that blood in you, as long as you can use it if you're not having any complications or problems. This is kind of an older therapy. Some people are still using it. I don't really spend a lot of time with this. This is a suppository you put in the urethra. It's the same thing in terms of increasing blood flow into the penis. It's the same medication. It's just a different mechanism in terms of putting it in the urethra. What's better, injecting the penis or putting this in urethra? And then, of course, you got kind of rubbing around the urethra. So it's really quite awkward. Again, same stuff, it takes time, 10, really 20, 30 minutes for it kind of works. It can cause pain, obviously, penile pain. I've seen some bad urethral pathology from it. Not highly favored much. This is what's called a malleable penile prosthesis or a malleable implant. A malleable implant is essentially some semi-rigid rods, or it's a device, an implant that you actually put in the penis, and it is measured, what I say, size to fit. So it goes all the way down underneath that pubic bone, and you measure the entire penis. It's also, of course, appropriate for girth, and of course, there's one on the left side and one on the right side. Now, this will make a little bit more sense here after we get to the next actual couple slides. But this is very simple. It's very easy to activate, very easy to use. A lot of guys actually ask about that. They come in and I don't know if they're half joking or half serious. And they say, well, can't you just put a rod in there and let me use it? And the answer is, well, yes, you can. I mean, it's actually very easy. This malleable penile implant will stay in that tissue plane. It'll stay in the penis. It'll stay in there forever. And you can bend it. And that's why they say it's a semi-rigid. So, a guy can kind of bend it down or he can bend it up to use it. So it's a wonderful option, for guys that don't have a lot of dexterity. And I'll get into that and why that's that way. It's totally concealed, totally buried within the body. But of course, the downfall is, it does stay a little bit erect. Now, guys worry, and they always ask me, well, aren't you walking around with an erection with it? And you'll be surprised. Really, the answer is no. You can't tell. You don't see it. It's really not that obvious. But that compared to this, which is an inflatable penile prosthesis. Now, this is similar, obviously, in theory, right? Okay, so what you're doing is you're filling that space of the penis. Again, it's the entire length of the penis. And again, it's, measured to fit, right? So it's appropriate for your size, what you have, both your length and, of course, again, same thing, you measure a guy's girth. And again, there's two sides here, right? There's a left side and a right side. Now, this one is a little bit different, and it was designed to obviously be concealed. Nobody knows it's there. There's nothing sticking out. There's nothing that you can see. So this is a penile implant, all right? So a penile implant, will go through a video here, but the whole point is there's a reservoir with fluid here, okay? And this is actually tucked inside the abdomen. And the video will show you, but this fluid goes through some tubing, and this is a pump down here, and this pump is actually in the scrotum. And by using that pump, you're putting fluid into those cylinders, into those chambers, and you can make the penis fully erect, fully rigid, very, very, very firm. And it's wonderful for sexual activity. So the beauty of this is you can activate it anytime, right? It's not rigid or erect all the time. You can pump it up as much as you want. You can use it for as long as you want, and then when you're done, there's a little valve that you'll see on the video that you can deflate the penile implant. It definitely it doesn't affect the sensation. Okay. So number one, guys will say, well, does it feel the same? Wives will say, what does it feel like? And the answer is it doesn't do anything with the nerves, especially the nerves on the outside of the penis. So you still have sensation. And then of course, I always say you can orgasm, and you may or may not ejaculate. Now that depends on if a guy does orgasm, or if a guy ejaculates, or if a guy has a prostate, or if he's had certain medications that inhibit that. But it is there. You do have the normal sensation. The other question I get a lot of is guys will say, is it a one size fit all, or like small, medium, large, or how does it work? No, it's actually very, very specific. And what I tell everybody, and by the way, I guess I kind of forgot to tell you, this is a surgical procedure, right? It's an implant. So this is a surgery to put this in. And what you do at the time of surgery is you make an incision above the penis, and then I do fill the penis with saline to create an artificial erection. And a lot of guys, you have to, kind of hold that saline in place because they might have a leak problem, right? The saline bypasses potential arterial problems. So anyways, you create a full erection, you see what they have, and then you measure it on the inside, and you say, hey, this is his measurements. This is his length. This is his girth. This is what he's got. And obviously, you put in the right size for the right patient. So that's a very common question I get. I'll talk about surgery here just a little bit, but this is a model of the implant, okay? And this is an implant in the flaccid state. The tips are nice and soft. There's a pump here. It's very easy to use, very easy to squeeze. And then of course there's a valve right here which deflates it. This is the reservoir that has the fluid that goes inside the abdomen. And so you pump these up, and again, it's the whole entire length of the penis. So when you're flaccid and you get an erection, you've got a nice firm straight penis or straight erection. Again, it's a surgical procedure. Some patients go home the day of surgery. Some patients will spend the night. I try to do it all through one little incision. Generally, that incision's above the penis. You can do it with an incision below the penis. Most patients will end up with a catheter in their bladder and a drain. We tend to sit on ice for quite a while, at least a couple of weeks. We don't do much. Everybody says, how much time do I need off work? And you say, well, you need at least 2 weeks, but I'll tell you, 4 weeks is better. Scott will tell you a lot more here, and you're going to get a lot more detail. So I'll let him kind of get into that. I want to get to this video, and we'll see if I can do it right here in just a moment. You'll see this implant. Of course, with it being surgery, there's risk. I say, hey, there's risk with any surgery in terms of anesthesia. Generally, we do this with a spinal anesthesia, and so you're kind of numb, from the waist down. You can avoid general anesthesia. A lot of my patients really like that. You can do general. It is an option. So it's obviously a surgical procedure. You got to be very careful. There's some risk. I'm going to show you this video. I've got some other videos on my website or my YouTube page, actually, and I probably should kind of plug that. But there is some videos on my YouTube page. It's, just look up Dr. Wiebusch, Wiebusch, Dr. Wiebusch on YouTube. I've got some nice videos, and they're used or they're for, the intention is for my patients that are thinking about it, my patients that are going to have surgery, for preoperative instructions, postoperative instructions. So there's quite a wealth of knowledge, but I don't need to spend a lot of time on that today. Now, this is the implant video. And what you're going to see here is he is going to pump it up, and the fluid's going to flow from the reservoir. So this is the reservoir. The blue represents the saline. Again, it's filled with saline. Everybody kind of worries about that or questions about that. The cylinders go underneath the pubic bone there. You can see it. The pump's in between the testicles and the scrotum. It's pretty easy to pump up, nice and smooth maneuvers. And you pump it up until you can't get any more in, until that thing's as rigid as you want. You use it. And when you're done using it, there's a valve up on top of the pump that you deflate. I'll tell you, with this implant in, that is a very flaccid penis. I mean, that's the way it looks. And so typically I say, guys, if you were a grower and not a shower, you tend to kind of be a shower now, because that implant, fills out that space. Yes, it's flaccid, but at the same point, it's filling out that whole space. So that's kind of the way it works. We do want to make sure, and check your insurance. It's a standard with all products, with all surgery, with medications, with injections, vacuum erection devices. You check insurance and make sure it's covered. It's interesting with erectile dysfunction. The insurance companies don't tend to pay or cover for medications. They don't pay for injections. They don't pay for a vacuum erection device, but they care enough that if you need an implant, that they tend to pay for an implant. Of course, though, we'll check it, and it's our job to do that, not yours. Another source, oh man, you can get information everywhere, right? So coloplastmenshealth.com, a ton of videos, a ton of information. You can look at the products, and they can help you out as well. My office here, obviously, in Lincoln, we're here for you, right? We're a resource for you, so we'll be available. All right, so I want to pass this over to Scott, and hopefully, with any luck, this will work here, and we'll let him just kind of keep going, and then when he's done, if there's any questions, we can kind of get through those. So I'm going to go ahead and try and mute myself, and we'll let Scott take over.
Hopefully, you can hear me. My name's Scott. And a year ago, I would have said I suffer from ED and I was ashamed of it. But now I would say, hey, I'm Scott. I have an inflatable penile prosthesis, and I really want to shout it from the rooftops. I've just been so happy with the change in my life. So a little bit about my story. I was diagnosed with diabetes and hypertension in my late 40s and started having a decrease in my erection. I tried the Cialis, the Viagra, the testosterone. And then by the time I was around 57, I pretty much totally lost all sexual erections. I could still get some nighttime erections, but nothing for sex. And so I turned to the injections into my penis, and they worked for me. And, there was the big pro. I could get an erection for sex, but there were the cons of it. Sometimes the erection lasted 4 hours. Sometimes I didn't get a good injection and it didn't last long enough. You had to wait. They didn't want you injecting more than once in a 24-hour period. I didn't always have my meds with me. It was difficult to obtain because it had to come from a compounding pharmacy. The nearest one was in Omaha. It had to be shipped refrigerated. It was a pain. And one of the big ones, it was non-insurance. Something I do want to say here, we are talking sex here, that kind of stuff. Hopefully I don't insult anybody if I actually say a non-medical term for something. I try to stay in that term, but sometimes things slip out. But talking about the road to my implant, I had gone on into the urology office here to get my injection medicine prescription refilled, and the PA suggested, hey, have you thought about implants? And it kind of planted that seed in my head, but I kind of thought, I'm not there yet. But then I attended a live seminar like this with Dr. Wiebusch, and was just really impressed by his attitude, his candor, and his openness, that sort of thing. And then I actually spoke with an educator like myself to ask them about their experience. And excuse me, I have notes here and I'm trying to read here. So then I had a weird stroke of luck last year. I had to have my appendix out. So I had my appendix out, and then I was looking at my insurance and realized I only had about $1,200 left of out-of-pocket expenses to pay. Otherwise, insurance would pay it all. So I thought this would be a good time to maybe think about it. Then it was August last year. My wife and I were camping for the weekend. We kind of got romantic in the evening. I didn't have my meds with me. I really couldn't perform, but I tried to do for her what I could. Well, then I woke up in the middle of the night with a nocturnal erection and kind of attacked her, but it didn't last long enough for us to really do anything. And then in the morning, again, we were still kind of feeling romantic, and again, couldn't perform, but did what I could to help her out. And that's when I told her I thought this is something I wanted to investigate. And so, I made my appointment with Dr. Wiebusch, went in and he did the physical exam. We did the history. He talked to me about there is a difference between the nocturnal erections or the nighttime erections and the sexual erections. And even because there'll be people out there that'll tell you, well, if you can get hard when you're sleeping, you don't have a problem. Well, they're wrong. He did the injection with the ultrasound, and then called me back, for an appointment like a week later, and verified, my ED, that I was a candidate for procedure, and that insurance was going to cover it, and we actually scheduled it. Well, a couple of weeks before my scheduled surgery, we kind of had a resurgence of COVID, and the hospital said, hey, you can't come in and have a surgery if you have to stay overnight. And the plan was for me to stay overnight. And they announced this on a Friday. And I appreciate Dr. Wiebusch so much. He called me on Saturday and said, hey, I know it's important you get this done this year because of your insurance. And I've been thinking about it, and I have a plan that I think you can just go home the same day. I'm going to have a little bit more expectations of you, but I think we can make this work. So it really, like I said, I really am impressed with him for, those sorts of things. So then preoperatively, I did have a vacuum pump that I had tried before. So I was pumping every day from the time I scheduled surgery until my surgery to have that penile rehabilitation, basically trying to stretch those tissues, open that area up so that when we did get the implant in there, I could get my maximum result out of it. And then, a couple days before surgery, I started taking showers with Hibiclens, kind of a hospital-grade soap, just to help prevent any infections after surgery. The day of surgery, I was admitted at 5:30 in the morning because that was the first case of the day. They shaved me, and again, they shaved me nipples to shaft. I thought it was a little excessive, but it is what it is. I had the spinal anesthetic, which was incredible, so much better than a general. Because again, the pain, if you have a general anesthetic, that pain relief is gone as soon as you start to wake up. With the spinal, that lingers on for a few hours. And my surgery, I did have the one incision right at the base of my penis, and they were able to place the reservoir, the pump, and the cylinders all through that one little incision. But I did leave the operating room with a catheter in my bladder, and that draining blood, and my penis and my testicles were pretty much wrapped up like a mummy. I had minimal pain post-op in the recovery room, or the PACU. I did have some IV meds, but other than that, I just had oral meds the rest of that day. I ended up going home that afternoon with my catheter and my drain. I went home. I kind of had a nest made for myself. I laid flat. I had ice on it. Doctor wanted pressure on my pubic area, like where my pubic hair would be. So I had gotten a 10-pound bag of sugar and stuck it in a big Ziploc bag and held it on there for pressure. I was taking my meds. I was taking antibiotics, stool softener so you don't get constipated. Ibuprofen was mostly what I took for my pain relief for those first couple of weeks. I think I maybe took 4 of my main pain pills. Other than that, the ibuprofen was just doing a great job. The next day I went back to the office and he took out my catheter in my bladder but left the drain in because I was measuring it as I drained it, and we were still getting a significant amount of blood out of there, so we didn't want that blood to accumulate in there to cause swelling and problems. So then I went back the next day and got the drain removed. So those first 2 weeks, I pretty much lived flat on my back on the couch with ice. I wore 2 pairs of underwear, supportive underwear. I could put the ice between the 2 pairs of underwear, and it really held it in place better than just trying to balance it there. And then doctor also wanted me switching sides. He wanted my penis either to the left or to the right, so I would switch it every day. And what I did to kind of keep track of it is on the even number days, I put it to the left because left has 4 letters in it, which is an even number, and right has an odd number. So even days it was to the left, right, odd days it was to the right, switching it back and forth. And again, taking those ibuprofen and my other meds pretty religiously. I had a follow-up a week afterwards in the office. Basically, he looked at it, thought everything was going great. So we just, like, okay, I'll see you in another week. I went back the next week and he's like, did my exam, like, hey, I think we can start inflating it today. And I'll tell you, it necessarily wasn't a pleasant experience that first time. I think I almost passed out at the office, but it was pretty amazing. The problem was he told me that day that I could actually go home and use it. And so, of course, I went home and told the wife, and we went to bed, and I pumped it up and started using it, and I was uncomfortable. And all of a sudden, it's like, I got to let this thing down. I didn't have enough experience with the pump to understand deflating it very well. And so here I was pretty much laying on my bed, squirming around, trying to get this thing to go down. That finally did succeed and stuff. Also that day, he did give me a model of the implant that helped me understand it a little bit better. But so for the next couple of weeks, I was inflating it daily for like 15 minutes as instructed by doctor. And those first few days, I was watching the timer. It was, waiting to be able to put it down because it was very uncomfortable. But after about the first 10 days, it really got a lot better. And, I got a lot more comfortable with it. I did have a few times with deflation issues. And the best instruction or note I ever got from anybody was one of the nurses in the office goes, hey, you've been driving an automatic your whole life, and now all of a sudden you're driving a manual. It's going to take you time to get used to driving, working this thing. So then my true initiation of actually using my implant was 15 days after we started inflating it. And I was to the point where I could inflate it comfortably every day. I could get it deflated, just a much better experience for me. And so I actually planned a weekend for my wife and I at a local hotel so that we didn't have household worries to worry about. We could just be ourselves and that sort of thing. And, had champagne in the room, got her a new nightgown, went out to eat to Misty's. So just made a whole weekend to kind of celebrate this. And it was a great experience for us. We, from then on, our sex life went from, once every few months to multiple times a week. It can be multiple times a day. But again, it's just changed a lot. there's things that are going to happen to you if you have this surgery, and you have to look at it as from the right aspect. I've heard people say, "Oh, my shape's not the same, my size isn't the same, I have a different angle." I thoroughly bet that anybody that says that their size is smaller hasn't measured their penis since they were 20 and don't realize all those years they weren't getting erections, they were losing penis. But again, if the shape, size, or angle does change, the biggest change is you're going to get hard. You're going to have an erection. You can have intercourse. And that's the best thing of the whole. And again, like Doctor said earlier, I used to be a grower. I'm now more of a shower. But I do think that even if I was like in a public restroom at a urinal or in a public locker room, nobody's going to think anything about it if they saw me. One of the other things about it is you have your options for your, sometimes you want it really, really hard. Sometimes you just want it kind of medium hard. Sometimes, you can play around with it soft. You do have all those variances that you can do. I also, we had to kind of adjust our position because, again, my angle of erection has changed. So we kind of had to play around with positions that work best for us, and we found the ones that work really good. And, other than that, it was a major step I took in my life, but I really haven't looked back and questioned if it was the right thing or not. I wish I would have done it sooner. If any of you guys go and talk to Dr. Webush, he has my contact information if you want to reach out and talk in person. Fortunately, I'm on a vacation for the next 2 weeks, so kind of out of touch. But after that, I'll be back and very welcome to talk on the phone or whatever to you or your partner or both of you, or my wife is willing to talk if there's questions that your partner would have. I can't guarantee everybody was going to have the great experience that I've had, but it has been wonderful, and like I said, I don't look back.
That's fantastic. I hope everyone can hear me. I think the sound's back on. I think first of all, we do have Scott's contact information, and he is so kind. He's willing to talk, and yeah, I mean he'll share his experience with you, but also he can talk to you through yours and help answer questions. So we do have his contact information. He does also work, so of course when we give you this, he'll call you back or whatnot. So it's nice for him to be there. I hope you have a good vacation, and I think it was really neat that he was able to get on tonight and talk to us and do this. It just speaks to how he feels about this, the passion that he has. He's obviously a wonderful man and gentleman and spouse, and this is important, and this is hopefully helped him obviously quite a bit. So it speaks a lot. Here he's on vacation getting ready to start something fantastic. We all wish we were. It's raining outside. It's going to be cold in the 40s next week, so have fun, Scott. Good for you.
Am I still on?
Yeah, of course.
There was something else I was going to say, but now it flew out of my head. Oh, heck. Like I said, it flew out of my head. I thought, I need to say this.
That's okay. You still have time if it comes to you. There is a question. Okay. So I can kind of go through that, and you can interrupt anytime.
Okay.
But there is a question, and it says, is the malleable rod implants a simpler surgery? And the answer is yes and no. As far as simpler, you're just putting in the rods. Same thing. You're creating the erection, same incision, creating the erection, measuring it out, putting in the rods. So you don't have to worry about a reservoir, and you don't have to worry about the pump. Same thing. Some patients can go home. Some patients will spend the night. We do leave a drain, and we do leave a catheter. So it's very similar. Now the healing does tend to be a little bit quicker because, like Scott had said, doing the pumping can create some discomfort, but we want to kind of stretch things out, stretch the penis out, get it cycled, get it going, get it working. So from that perspective, you'd say, yeah, you don't experience that. You just have the implants within the penis itself. So recovery does tend to be faster. Recovery. Scott, I don't know if you can hear or see this one, but there's a question for you. It says, you said you wish you would have, you said you wish you would have done it sooner. How much sooner?
Well, I wasted 4 years doing injections. So really, when I lost my main ability for sexual erections, like I said, I did the injections for 4 years, and that was a wasted 4 years, as far as I'm concerned. Because again, even though we were using it, it was just so inconvenient. We didn't have sex that much. I work a lot out of town. I used it more for my own self-pleasure when I was alone than I did with the wife, because there were times, like I think, oh, I'm going to go to bed and we're going to have sex, and I'd inject, and it'd be nice and hard, and I go in the bedroom and she's not in the mood. So it's like, oh shit. Or, the times where she's in the mood, we're in the mood and I don't have my meds with me. So it's just a fact. I'm spontaneous whenever I want to be. I can last as long as I want to last. And a lot of guys don't understand this, but it has nothing to do with ejaculation or, so if you ejaculate, you're still staying up until you let it down. It's not like your typical normal erection. I have my orgasm, I go down. No, it's up for as long as I want it up. And again, it's as hard as I want it, it's as soft as I want it. So yeah, I wasted 4 years.
There's another question for you. It says, how does the pump feel in the scrotum, and how uncomfortable or do you notice it, I guess?
I talked to a patient a couple of weeks ago, and this was his big question, and I was like, you know what? I don't notice it. But then after talking to him, it's like, maybe I do notice it a little bit. But as a general rule, it just becomes part of your norm. But as a general rule, I don't think I notice it. There's times my testicle hurts that bothers me more than this ever has. Because again, it's there. It's not that big. There's more room in your scrotum than you really think. Sometimes I do have an issue, like, going to deflate it when, everything's all pulled up tight. Sometimes it's hard to get to the valve, and so I kind of have to pull it down, that sort of thing. But honest to God, I don't feel anything. It's there, and kind of like I said, I think one time was, it's kind of nice when I walk up to the urinal, I'm not having to search for it anymore, because I am more of a shower now than I was before, and it doesn't turtle away anymore.
Do you worry? Do you worry about this cruise? Do you worry about swimsuit? How do you feel being out in public like that?
Like I said, I'm not worried about it at all. And there's times, I have, when I don't go to deflate it, sometimes it deflates more than others, But again, it's just kind of, I look at beforehand, there was times my penis was different sizes depending on the situation. So this is just, maybe I have a little bit more control over, but I'm not worried about it.
Okay.
The weirdest thing that happened to me is yesterday is the first day I've flown since I've got my prosthesis. And I was in Omaha and it had the body scanner, and the metal detector wouldn't have detected anything, but the body scanner did. So I had to tell the people, I got a penile prosthesis. That's what you're seeing. And I did have to kind of have a pat down, but I'm like, hey, if that's the cost for me to be able to travel and still have an erection, it's no problem.
What did they do? Did they detect it? Did they pull you aside? Tell me what happened.
Well, basically, I went through, and it's the scanner, and so it shows like a drawing of a person, and it showed like a yellow box over my crotch. And I told them, I said, I have a prosthesis. And they said, so you have a medical device? I said, yes. And so they said, well, we need to do like a pat down. Do you want to go to someplace private? And I'm like, no, I'm fine. So kind of got a little pat down. And again, like I said, if that's the price that I have to pay to be able to travel and have great sex with the wife, then it's well worth it.
Did they ask to see like a device card, or they didn't touch you?
No,
did they? They
didn't, and that makes perfect sense to me because anybody can get a card off the internet that says I have something, So, but again, it is what it is, and I don't know if I should say this or not. I told my wife I should have had it pumped up more, then they maybe would have found the weapon. But it is what it is.
God, that's great. I think that's great. There's a couple of questions that are all kind of around the same topic here. And the questions essentially are, did you notice any changes in your sensation? Did you notice any changes in sensation, and then obviously orgasm and ejaculation?
I'll have to say my orgasm and ejaculation is not a good topic with me because in the past 15 years, I probably ejaculated 5 times from penetrative sex. It just doesn't seem to work. For me, I take care of it myself, sort of thing. And again, so I have found with myself, if I'm going to just pleasure myself, I'm best off being soft. It just works better for me. But from an intercourse standpoint with the wife, it's great, because the thing is, I still get like that blood pressure rush, that heart rate rush when I'm pounding away, and kind of still have that, like what I think, that little like letdown that you have after you have an ejaculation. I have that without the ejaculation. As my body's kind of returning to normal. And the thing is, because I am not coming, I'm just as happy to go again. Where, some guys are going to shoot and then they're like, I'm done. So from that standpoint, I can't complain. Because again, I'm no worse off than I was before.
And that's another question here, is your sexual activity, do you find it the same, better, or worse than before when you were sexually active, when you had good erections?
We've been married 38 years next month, and we're having more sex now than we had as newlyweds. And again, and I think it's more, if you think about the period of time where I was having issues, we're much more laid back, because there was that period of time where it's like, it's hard, we got to do it now. Where with this, it's like, we can have we can have some, foreplay stuff. I can pump it up whenever I want to pump it up, and we can go for it. I can let it down. I can put it back up. I can, soften it up. I can harden it up. I can just do so many different varied things with it. And, that's, it's just, and I'm not tied to like, I have to worry about how long am I going to last? How long is my erection going to last? It's going to last as long as I want it to last. If that makes sense.
There's another one. Obviously, the classic question is, would you go through this again?
Hell yes. Like I said, because again, I am 62. So hopefully I live long enough that I wear this one out and have to have a replacement. And again, surgery was not that bad. I know I was going to say earlier too. I think the biggest thing is that, and hopefully people online understand this. This is more people than I've talked to in my personal life about this. So friends and stuff, I have like 5 friends that really know what's going on. I have family members that don't even know. And here I'm talking to you guys because I am passionate about this, and, it's nothing to be ashamed of. And there's something we can do, and you shouldn't have to, give up this pleasurable part of your life just because you're getting older or you have a disease process that's affecting you.
Yeah. Well, I don't want to take up too much of your time. I think you've really done a very nice job tonight, going through this and answered all these questions. I don't see any more questions on the Q&A. I appreciate your time. I hope you have a wonderful, wonderful vacation, and be safe out there. Okay.
Well, I know I'm having sex every day. My plan is that way.
Rock the boat, right?
Yeah.
Oh.
But
all right, everybody.
And again, I hope everybody, anybody, that comes and talks to you and wants to chat, I'm very open. And I'm here for you because this is not an easy time. Most of us don't have good friends to sit down and be able to talk to and say, hey, this is what I'm having done. The other thing I'll tell people, if you do decide to have it done, come up with a story in advance. What kind of surgery did I have? Because people are going to find out you're in the hospital. They're going to want to know because they care. And so, might tell them it's a hernia or something like that. But, there may be those few people you're going to tell, this is what I had done. But, have a story out there for them so that you're consistent.
That's obviously, that's a great point. This is a very private thing. This is a personal thing. It's a personal decision, and a decision made, hopefully with you and your spouse in mind. And obviously that's what we encourage too. So very nice. There was one other question. I'm not really sure what happened. It was something about the shower versus grower. I think it may have asked, if you deflate this, are you able to be totally flaccid, or as flaccid as you'd like to be?
Well, I think I can be totally flaccid. The thing about being a shower now is, with the prosthesis, it doesn't shrink much in length. When I deflated it, mostly shrinks in girth and hardness. So I still tend to have that length that I wouldn't have had before.
Yeah, I think that's right. I think that's what the question was going to, but I'm not real sure. It kind of disappeared here, but yeah, I think that's important to know. It takes up that space, but you can get it flaccid. You can be comfortable, and you can walk around, go out to the restaurant, and nobody knows what's going on. So,
I think about days, when you were 16 and you had you had an erection and your jeans and you were uncomfortable and stuff. It's not like I'm ever uncomfortable, because I have total control over it. And, and again, like some days it seems to deflate better than other days, but there's just that learning curve. And I think there's guys out there that get to a place to where it's like, maybe I don't want it all the way deflated. Maybe I want it a little bit more inflated just to make me feel better, because it is, like I said, it is kind of a nice feeling to stand at the urinal and reach in and not have to look for it. It's just there and ready for me.
All right. Very good. We'll wrap this up. Thank you, everybody. You can contact our office if you have any questions, if you'd like to be seen, if you'd like to come in for consultation and see myself, Dr. Weebush here. I do have Scott's information as well. So you can check out our website. I do, again, have that YouTube channel with some videos that are informative. Dr. Wiebusch, Wiebusch. And our phone number here is 402-489-8888. So on behalf of Coloplast, I want to thank everybody for attending. And I want to thank Coloplast, obviously, for helping put this on and put this together. They make this very nice, very easy. We're able to connect with Scott, who's getting ready to go out on a cruise. This is fantastic. It's crazy. It's wonderful. It's beautiful. It's absolutely fantastic. Thank you, Coloplast. Thank you, everybody. Have a good night.
Thank you.